is regional anesthesia in pediatric patients. I will present my topic in the following subheading, sir.
Okay.
Introduction. What are the benefits of pediatric regional anesthesia? Relevant anatomical and physiological differences between a child and adult regarding regional anesthesia, and what are the procedures of pediatric regional anesthesia in general, and choice of local anesthetics, and what are the additives to be added, and certain controversies regarding pediatric regional anesthesia. Finally, the contraindications. Coming to the introduction, regional anesthesia in children has gained acceptance worldwide over the past few decades. There is a good evidence that regional anesthesia provides good quality post-operative pain relief. Main important thing is advances in ultrasound technology have enabled practitioners to perform regional blocks in children with safety and greater accuracy. Coming to what are the benefits of pediatric regional anesthesia? By providing successful pediatric regional anesthesia, it reduces post-operative pain scores. So when compared to the general anesthesia, successful pediatric regional anesthesia provides good post-operative pain control, which provides comfort not only to the child but also the caregivers, that is nurses, the parents, and the doctors in the post-operative ward. So the patient calm, composed, sleeping baby is more comfortable than agitated, distressed due to pain. Second is there is decreased opioid consumption and GA anesthetic agents. So complications regarding general anesthetic agents can be reduced with properly placed regional anesthetic. And there is reduced incidence of post-operative nausea, vomiting, and also the respiratory complications. So successful place regional anesthesia causes early ambulation and short hospital stays, so that economically feasible. Coming to the what are the relevant differences between the child and the adult? Coming to the anatomical, most obvious difference between a child and adult is the body size. So at birth, the dura ends at the level of S3, S4, and the cord, that is conus medullaris, at L3, L4. So it is only at the end of first year of life that the adult level is attained. That is L1 for conus medullaris and S2 for dural sac in case of adult. So caution while advancing the needle should go below this level to prevent injuring these structures. And Tappier's line will cross at the level of T5 to S1 in, in case of infants and older children. However, in adults, it crosses around L3 to L4. Second thing is there is delayed myelination of nerve fibers. As a result of delayed myelination, especially in infants, which is not finalized before the 12th year of life. A major pharmacological consequence of delayed myelination is the local anesthetic can penetrate and block nerve fibers more easily. So onset of time is shortened. Onset of time is shortened with the risk of more prolonged motor blockade even with low concentration of local anesthetic. The duration of block, however, the duration of block is reduced because the trapping of local anesthetic within the myelin and with subsequent progressive release is reduced, and vascular absorption is greater in infants, and moreover there is increased cardiac output in infants. So the onset time is shortened and duration of block is shortened. So by adding the additives, we can prolong the motor blockade. Coming to the, there is third point, delayed ossification of bones. So due to delayed ossification of bones in neonate and infant, avoid bone contact as often as possible, because as these sharp needles can penetrate the cartilaginous bones and accidentally we can inject the drug within to the cartilaginous bones, and also will can damage the bony nuclei. So as far as possible, go in the midline, avoid contact with the bony structures. Fourth point is curvature of the spine and the fusion of the sacral vertebra. In neonates, there is a single spinal curvature with a high degree of flexibility. When it comes to infant, The cervical curvature appears at 3 to 6 months and lumbar curvature at 8 to 9 months. In adults, there is thoracic kyphosis and lumbar lordosis. So as a result of this, in infants and neonates, there is increased cephalic spread of local anesthetic due to lack of lumbar lordosis compared with adults and adolescents. While performing epidural in adolescents and adults, a steeper ankle needle insertion may be required when performing. However, in neonates, it comparatively less steeper angle is required. Coming to the sacral hiatus. The sacral hiatus serves as a portal of caudal injection until 6 to 8 years of age, when the fusion typically begins. So, sacral epidural approaches possible until fusion complete. The sacral bony fusion completes by 25 years. So, it is easy to perform the sacral caudal epidural at the age around 6 to 8 years of age. The fifth point is there is loose attachment of fascia and sheath and fluidity of epidural fat up to the age of 6 to 8 years. The consequences are infants and neonates, there is a leakage of local anesthetic around the nerve fibers. So relatively a high volume of local anesthetic will be required to achieve the desired lock. And in neonates and infants, it is easy to thread the epidural catheter several centimeters along the epidural space without resistance, allowing thoracic level epidural catheter to be threaded from a caudal or lumbar portal entry. Sixth point, ligaments and CSF volumes. In neonates and infants, ligaments are less dense and highly vascular than in adults. So loss of resistance is subtle as compared with that of adults. And as a result of highly vascularity, there is increased systemic local anesthetic absorption. Coming to the CSF volume. In neonates, it is around 10 ml per kg. In infants, 4 ml per kg. In child, 3 ml per kg. When it comes to adult, 2 ml per kg. So it gradually, the CSF volume is decreasing. So as the CSF volume is more in children when compared to adult, a relative large dose of local anesthetic is required when performing spinal anesthesia compared with adults. For example, when 0 to 5 kgs will give around 0.5 mg per kg, 5 to 15 kgs 0.4, more than 15 kgs 0.3 mg per kg. Coming to the what are the physiological differences? As sympathetic nervous system is immature in neonates and children, peripheral vasodilatation and hypotension are less common following central neuraxial blockade. So as a result, these patients may do not show that much hypotension when compared to the adults. Coming to the pharmacokinetics in children's, due to increase in cardiac output and low tissue binding, which results in high rate of systemic absorption. So shorter duration of local anesthetic action. Coming to the distribution, neonates have high extracellular fluid volume, high volume of distribution. So they require high local anesthetic when compared to the adults. Coming to the metabolism, in children's there is lower concentration of alpha-1 acid glycoprotein until 1 year of age, and hepatic metabolism of local anesthetic is not fully functional until 9 months of age. As a result, there is increased concentration of unbound free fraction of local anesthetic. So there is a risk of drug accumulation, especially after repeated doses or continuous infusion, not with a single shot. Coming to the clearance, when it comes to bolus administration, up to 2 years of age, clearance decreases and elimination half-life of local anesthetic is prolonged. As a result, free fraction of local anesthetic is increased. When more than 2 years, clearance and elimination increases progressively, even exceeding that of adult before returning to the adolescent. Coming to the clearance after continuous infusion, as alpha-1 acid glycoprotein increases on POD 1 and 2, which protects against local anesthetic systemic toxicity. However, on POD 3, the alpha-1 acid glycoprotein decreases, resulting in increased free fraction. Thus, it is advised to stop local anesthetic infusion in infants after 48 hours. Coming to the procedures, regional anesthesia in children. Before performing any regional before
அனுப்பிருக்கேன் பாத்துக்கங்க வாட்ஸ்அப்ல அனுப்பிச்சிருக்கேன் பாருங்க. சரி.
Coming to the procedures, before performing any regional procedures in children, check anesthesia workstation, breathing circuit, face mask, availability of appropriate size laryngoscope blades, ET tubes, airway, suction, and availability of GA drugs and emergency resuscitation drugs. So while planning a regional anesthesia, think it as general anesthesia and should be well prepared. Make sure IV line in place and properly functioning, and standard ASM monitoring include pulse rate, BP, SpO2, ECG, and precordial stethoscope. Regional anesthesia may be used as a sole anesthetic technique with minimal sedation, or it can be combined with GA. Most of the times it is combined with GA, so the drugs required for GA can be reduced with better postoperative pain scores. So successfully placed regional anesthesia, we can reduce most of the drugs. So most of the time these patients will be sedated by giving IM ketamine. If IV cannula is inside, we'll give IV outside and bring the child inside, and most of the times these are done under sedation. Most common procedures which are done are single shot epidural, caudal epidural, or single shot epidural, caudal epidural catheter placements, or ilioinguinal, or penile block for circumcisions. However, ultrasound innovation guidance today allowed to perform various peripheral nerve blocks, placement of peripheral catheters, thoracic and abdominal blocks. So USG advantage is permits a careful evaluation of anatomical targets, visualization of vital structures surrounding the nerve. Moreover, most important thing is high volume of local anesthetic previously used during landmark guided regional blocks are replaced with reduced volume of local anesthetic with target specific and with decreased complications. By performing ultrasound regional technique, the in-plane technique maintaining the needle path along the transducer long axis is the technique of choice in children, as it permits continuous visualization of needle tip and its entire length during performance of block. Coming to aseptic precautions. Regional blocks must be performed under strict aseptic precautions. One thing should be remembered is for children younger than 2 months, chlorhexidine 2% or 1% can cause chemical burns, so alcohol is preferred. Coming to the local anesthetic choices. Amide local anesthetic are frequently used in pediatric regional anesthesia. Ropivacaine and levobupivacaine currently considered less cardiotoxic than bupivacaine because relatively higher proportion of cardiac sodium gated channels are in the open state in children with a high affinity to local anesthetic. So ropivacaine and levobupivacaine are better, less cardiotoxic. If you want to choose ester local anesthetic, then you can go with tetracaine or chlorprocaine, which are metabolized by plasma cholinesterase. Most important thing is weight-based calculation of maximum local anesthetic is essential in avoiding life-threatening loss. The recommended doses of most commonly used local anesthetic are ropivacaine single shot is 3 mg per kg. Hourly infusion is 4 months to 1 year is 0.25 mg per kg per hour. 1 to 4 years 0.35 mg per kg per hour. More than 4 years 0.4 mg per kg per hour. Bupivacaine 2, levobupivacaine 3 mg per kg is maximum bolus dose allowed. When come to lidocaine, we can use 5 mg with 10 mg with adrenaline, but for continuous infusion, it is not recommended because continuous infusion results in substantial decrease in intrinsic clearance because lignocaine metabolism is impaired by its own metabolites. Coming to the additives, the advantage of adding additives to local anesthetic is mainly to prolong the duration of block. Most of the time in pediatric patient, duration is shortened due to various reasons explained. So it prolongs the block and enables the use of diluted local anesthetic, especially in infants and children, and there is reduced use of IV opioids with concomitant reduction in adverse effects. Most commonly used are dexmedetomidine 1 mic per kg and clonidine are the popular additives which prolongs the analgesia. However, they are avoided in preterm babies and infants less than 6 months due to the systemic absorption and prolonged sedation. Other additives are morphine, epidural is 30 mics per kg, intrathecal 10 mic per kg, and fentanyl is 1 to 1.5 mic per kg, and you can use preservative-free ketamine 0.5 mg per kg. A word on last, local anesthetic systemic toxicity. Early signs of neurological toxicity are unfortunate. So most of the time, serious features will appear because of sedation or GA. The earliest signs are last or CVS, including the peak T waves and dysarrhythmias. So infants less than 6 months of age are highest risk for last due to unrecognized intravascular injection, rapid absorption, and decreased level of alpha-1 acid glycoprotein. All providers must be familiar with current last management guidelines and weight-based dosing must be followed. Coming to some of the controversies regarding awake or general anesthesia, whether regional block to be performed under awake or general anesthesia. The recommendations are in children performing a regional block awake or with minimal sedation may result in child distress and moving during block placement. Moreover, a frightened child is unlikely to report symptoms of loss. So ASRA or ISRA recommends that pediatric regional anesthesia performed under GA or deep sedation has acceptable safety and is considered to be standard of care. Coming to the saline or air for epidural placement, which to be should. So whatever the technique if you use, so by maintaining the minimum standards, both our techniques are equally acceptable. The total volume of air injected during identification of epidural space should not exceed 0.5 to 1 ml in infants or neonates. And currently there is no clear evidence regarding which technique is superior. Any of the technique are acceptable provided injected volume is kept to minimum. The third thing is what is the value of the test dose, xylocaine with adrenaline by addition of adrenaline. Adding adrenaline to local anesthetic to detect accidental IV injection in children is controversial because GA or deep sedation are both confounding factors for the correct interpretation of an increase in the heart rate. If a test dose, if at all to be used, then solution with 0.5 mic per kg of adrenaline or 0.1 ml per kg of local anesthetic containing 5 mic per ml adrenaline, that is 1 in 2 lakhs dilution, should be injected slowly with intermittent aspiration and ECG monitoring. Coming to the contraindication. Neuroaxial contraindications for neuroaxial blockade. Severe coagulation disorders such as constitutional, which could be hemophilia, or acquired such as DIC or therapeutic. Second thing is severe infections such as septicemia and meningitis. Third thing is severe hypovolemia. Fourth, intracranial tumor with raised ICP, true allergy to local anesthetic, or cutaneous or subcutaneous lesion at the site, or parental refusal. However, depending on the clinical condition of the patient and possibility to cure at least temporarily the impending disorders, regional block may be considered in spite of existence of this contraindication. For example, after correction of hypovolemia or injection of factor 3 or effective antibiotic treatment for treatment of septicemic child. So central neuroaxial block can be performed provided that the expected benefits consistently outweigh the risk by comparing other technique of analgesia. Coming to the contraindication of peripheral nerve block, true allergy to local anesthetic is the only absolute medical contraindication to peripheral nerve block. Coming to the summary, pediatric regional anesthesia is the essential element of perioperative care and should be considered in children undergoing surgery. It has a high safety profile and can be performed at GE or deep sedation. Safety precautions such as USG guidance, careful local anesthetic dose calculation should always be taken while performing pediatric regional anesthesia. Thank you, sir.
Very good. Okay. Just